25 years ago, I was a very new nurse. I'll say 10 years ago, I was a very new nurse. It was 25 years ago, and I had a patient come to me, and he was a medical oncologist. So, you know, had been practicing for about 23 years in medical oncology. And he had a very advanced buccal mucosa squamous cell carcinoma. So let me tell you his story. He developed a sore in his buccal mucosa, and he's a doctor, right? So he treated it himself, put himself on oral antibiotics, didn't get better, until it eroded about a 3-centimeter hole right through his buccal mucosa. He had this big hole in his cheek. So as a medical oncologist, you know what he did? He grew a beard to hide the hole and kept on practicing and just didn't do anything about it. And so by the time he came to us, he was very advanced squamous cell carcinoma of the head and neck. And he said to me, and I'll never forget this, and I'll probably cry telling the story, he said, Annette, he said, no matter what you do, he said, you know what, the hair loss was no big deal, the loss of appetite was no big deal. He said, but the oral mucositis was awful. He said it was so incredibly painful. It ruined his quality of life. He said there were times that he really thought that he wanted to end everything over oral mucositis. And he said, promise me that you will work hard to do something about finding a cure for the oral mucositis. Well, so I did. And here I am, right? It's 25 years later, and we still had nothing, absolutely nothing. So I'll continue that story as I go through my slides and tell you where we got from here, but there hasn't been much out there at all. And we'll talk about Magic Swizzle, but stop using it, please. It just doesn't work. So I have no commercial relationships at all. I like to put this in here because my big baby, I work in radiation oncology, and I'm a program manager. And I just like to show this just to show the advances we've had in oncology. So when I first started at University of Pittsburgh, we had a prototype. This is called a cybernetic machine, and it's very, very pinpoint radiation. So people that have lung tumors or brain tumors, pancreatic tumors, that, you know, really have had previous radiation, or maybe take a lung cancer patient that can't undergo, you know, chemo radiation therapy because they're cardiopulmonary compromised. We can do very, very pinpoint radiation now. Absolutely no side effects. People that used to go through huge lung, you know, resections, we now can target the tumor so precisely that we cause them absolutely no side effects. A lot of my surgeons don't even like to operate anymore because we have such good success rate with the cybernetic. So when I started, this is what our machine looked like. And then in 5 years, it now looks like this. So we've made these tremendous advances. We, you know, treat patients, and we've made advances. And my point of this is, you know, in a little bit of time, we've made such huge advances in affecting patient outcomes and affecting their quality of life. And one area we haven't done that is oral mucositis. And like I said, in 25 years of practice, and even going back 35 years, we've done absolutely nothing to help oral mucositis. And these patients continue to suffer, and I, you know, it's not dentistry at all, but my medical oncologist or my radiation oncologist are like, oh, it's short-lived, it's 7 to 10 days, you know, in radiation, it's 3 weeks, it gets better, and they, you know, they just brush it off. But like, you know, my physician told me 25 years ago, please try to do something about it. So mucositis is a common complication among cancer patients. We all know this. Tissues affected, your buccal mucosa, your soft palate, tonsillar pillars, lateral tongue, esophagus. It's progressive, it's painful, there's a lot of inflammation in the mucous membranes. It impairs eating, it impairs swallowing, it impairs quality of life. And the big thing, especially in our bone marrow transplant patients, is it causes infections and sepsis. And ultimately, we have had patients who have died due to oral mucositis infections. So what can we do? We can reduce the amount of microbial flora, reduce pain and bleeding, prevent infection, and reduce risk of any dental complications. You guys, and why I am so excited to be here, and I hate to fly, is probably why you couldn't get me here last year. I'm definitely afraid of flying. You are such an important part of our oncology care. And in my department now, we treat a huge amount of head and neck cancer patients, and I have a dietitian on site. She comes in 3 times a week. And I'm arguing with my administration that I don't need the dietitian. I can teach these patients, and half of them can't even eat, ensure peg to, what they need calorie-wise. I want a dentist in the department 3 times a week. You guys are what is so important to us with these head and neck patients and oral care. I mean, to have you on site even once a week would be a huge benefit, especially in our larger institutions where we see enormous amount of head and neck cancer patients. So we are currently working with our School of Dentistry to have a dentist come over at least once a week to evaluate these patients and their oral care. So we work with, obviously, practitioners, audiology, nutrition, speech pathology, smoking cessation. Integrative medicine has also become a very big part of our planning process. And then palliative and symptom management. You guys are very familiar with the pathophysiology. I wish our patients looked like this. They look 100 times worse than this. So we know the development of OM is very complex. It results from complex interaction of local tissue, local oral environment, the patient's level of myelosuppression, and the patient's intrinsic genetic predisposition. And it's so funny, the level of myelosuppression, because I not only treat all our patients in radiation, but the photobiomodulation has become so big in our hospital that I treat all the stem cell transplant patients. And it's amazing, as soon as someone's counts drop to 0, they can explode with mucositis. I saw the guy on Thursday, he was doing absolutely great, and then I go in the next day and he's just covered in oral mucositis. So it happens like that overnight as soon as they become myelosuppressed. The degree of injury of mucosal tissue is directly related to the type, dose, and dose intensity of chemotherapy. Not every patient is going to get oral mucositis. It depends upon the agents that they're getting. And now, in oncology, targeted therapies and immunotherapy is huge. I mean, chemotherapy is going to go by the wayside. We're really going to start doing a lot of targeted therapy and immunotherapy on these patients. And interesting, those patients tend to get a lot of aphthous ulcers. We don't see as much of the generalized mucositis, but we see the aphthous ulcers, and I have some really good pictures of a patient I just had, and I'll tell you a story about him, because I'm full of stories. Radiation therapy regimens, especially head and neck cancer patients, get horrible oral mucositis. The other end of the spectrum, which you guys don't care about, is our rectal and anal cancer patients, same thing, horrible mucositis, because obviously the canal goes all the way down. Myelotoxic conditioning regimens prior to stem cell transplant. In the current biological working model, we know it's 5 phases. So everybody thinks oral mucositis starts when we see the lesions, and we know that that is absolutely not true. It starts way before we see the lesions. So really, these patients need to start having good oral care, seeing their dentist, taking care of their mouth, and starting, laser therapy even before the treatments start. So we know initiation is usually when you get the chemo and the radiation and your DNA is damaged and you already have trouble. Once you have damage in the DNA, you have this message generation. So it releases cytokines, and the cytokines cause further damage. And what happens is you have signaling and amplification. Those cytokines then cause a positive feedback loop. So things just keep looping back around, and you keep having further damage and further damage. And ulceration is really the 4th phase of oral mucositis. So it starts way before, you start to see the ulcerations. And even patients, it's funny, especially my stem cell transplant patients, they'll tell me my mouth is starting to hurt. And it'll be 2 days later until they break out the oral mucositis, but they can feel it coming on. So, it's very interesting. And then you have the healing phase, which we wish we could say, oh, it's exactly 10 days after, but everybody is different, and it's just sort of when your body starts to recuperate. Just my fancy picture for the 5 phases of oral mucositis. So we talked about the factors increasing severity. So we know chemotherapy, we know the regimens, we know radiation therapy. Chemo and radiation together, forget it, they're a mess. Individual factors, the young, the old, the smokers, and the use of alcohol, which is, unfortunately most of our head and neck cancer patients, and then those that are superimposed to mucosal infections. I always like to touch on this because it's not the same. Mucositis in chemotherapy is very different than mucositis in radiation therapy. So OM secondary to chemotherapy typically presents on what I always say the movable mucosa. So, you know, their cheeks, their tongue is typically where you see mucositis in the chemotherapy patients. They begin the feeling of irritation about 3 to 4 days after infusion. Then it's accompanied by the ulcer development. And then similar patterns for patients receiving stem cell transplant. It increases intensity 3 to 5 days later and persists for another 3 to 5 days. And that's about what you see in the chemotherapy population. It's usually a very, I don't want to say very quick because to them it's forever, but it usually lasts about 7 to 10 days in these patients. So they'll get the ulcers and then it's about 10 days later where they have resolution of them. And you can pretty much predict that in the stem cell transplantation and chemo patients. In radiation, unfortunately, it's very different. There's a less acute onset and resolution compared to chemo-induced. They begin to develop soreness usually by the end of the first week of radiation, more toward the second week of radiation. They'll start to have soreness in their mouth. You know, they feel like it's hard to eat. And then the intensity increases until ulceration occurs about week 3. Now, these patients get 7 weeks of radiation. So the ulcers start about week 3 and they do not go away. And they persist not only after the radiation is done, but I have patients come in sometimes a month later still with ulcerations in their mouth. So with standard fractionation, single modality radiation, it develops around 30 gray. With chemo, we see it around 20 gray and forms very confluent mucosal ulcers by the end of week 3. And it could last, like I said, even a month after the radiation is done. One of our big problems in oral mucositis is we don't know how to assess it. And I will constantly, now that we're doing a lot of studies on OM, constantly my residents will say, oh, I have a patient, they have horrible, horrible mucositis. You know, the laser didn't work or this didn't work. And when I go up to see them, it's all esophagitis. And I'm not touching the esophagus at all. They have no oral mucositis at all. It's just all very bad esophagitis. But even my, you know, well-trained residents don't know the difference between esophagitis and oral mucositis. There's a lot of good scoring assessment tools out there. We tend to use the National Cancer Institute NCI tool. This is what I like to talk about, differential diagnosis. I'm sure you guys see a lot of this. So I will have a resident tell me that the patient has bad oral mucositis back on their soft palate, and it ends up being thrush. So this is basically what our oral mucositis looks like in the head and neck population. So it is very confluent. It's usually all over their mouth. They tend to get it very bad under their tongues, a lot of it on their uvula, so it can be very, very painful. This is not oral mucositis, and you don't know how many times I've called to laser patients for thrush. 1 million times. So I always tell my residents, take a swab and go like this, and if it wipes off, then most likely it is not oral mucositis. It might have some underlying mucositis, but I mean, that happens to me probably 3 times a week, that they think the patient has bad oral mucositis. We put the patient on diflucan and they're better in 2 days. So obviously that is thrush. Aphthous ulcers, we all know what those look like. You guys see 1 million of those. I get them horribly, so I'm a big fan of the laser because it works wonderful. And our patients tend to get them too. And then we do see a lot of herpes simplex in our patients. So once again, not oral mucositis. Can oral care prevent mucositis? It has not been demonstrated to prevent OM, but the adherence to a regimen can reduce the duration and severity. And this is where you're so important because our patients don't think it's at all important. And their mouths get sore and they get tender and they stop their mouth care and it just becomes awful inside their mouth. So we're really big on trying to help them do good oral care. So we've come to know that we can reduce oral complications, we can offer symptomatic relief, and oral care can enhance the quality of life during and after oncology treatment. And that low-level laser is awesome. So, you know, in 25 years, I've had nothing to offer these patients, absolutely nothing. And now we do. So just a little survey that I conducted several years ago with a colleague of mine at one of our congresses, and I like this is our big oncology nursing congress. So we had 558 respondents, and 89% of them identified OM as a significant problem. 57% said they had no institutional guidelines for the management of oral mucositis. And all of the magic mouthwash and Carafate or Sulfurfate were ranked as primary management strategies, and 67% of them said they were minimally effective. So that's fantastic. You know, I have all these people using things for oral mucositis that were minimally effective. So we know for pain is the hallmark of OM. It can be a distressing adverse cancer side effect, difficulty swallowing, eating, and drinking. A successful outcome depends on pain management. And then we have guidelines, actually, that recommend for patients that get oral mucositis, morphine. Just put them on morphine. So it's fantastic because I have these patients on the floor. As soon as they say their mouth starts to hurt, they get put on a PCA or a patient-controlled analgesia of Dilaudid or morphine. Now you have patients that aren't eating, they're nauseated, they're a false risk. And this is just, they don't even have the ulcers yet. As soon as they complain of their mouth being sore, they get thrown on a PCA pump, which is very frustrating. We talked about management of general principles. There is no magic in magic mouthwash, and we really need to stop using it. A lot of reasons in the head and neck cancer population, a ton of reasons, is because you know what? These patients get a lot of confluent mucus because we're drying out their parotids, so they're not making saliva. And when you're giving them magic mouthwash, they're at such a high risk for aspiration because those patients swish that around, they end up swallowing it. Now they have no gag reflex. It's awful. So we really should stop using magic mouthwash. And there are plenty of studies out there too that show that lidocaine delays healing. So we're putting lidocaine on things that we want to heal, but yet it's delaying healing. So our measures is we want to minimize symptoms. We want to, create new tissue of the mucosa. We have a lot of mucosal coating agents out there. There's their gel clears, your Epicils, your Mugards. They don't work either. They're not fantastic. We talked about lidocaine, benzocaine sprays, mucosal coating agents, antacids, kaopectate, and then we have Captisol gel clear. They're just mucosal coating agents. They really have what we call hyaluronic acid in them. And so basically they help to heal the tissue, but they form a Band-Aid over the mouth, but it doesn't tend to last very long either. So what do we do? So I have to tell you the story because this is where you guys become incredibly important in my life. And I'm so thankful for you because this is where it all started. So 2.5 years ago, 3 years ago, we had a patient who was getting head and neck cancer radiation therapy and chemotherapy. And the guy was into week 3 of his treatment and he still had no oral lesions, no mucositis, and we're like, So, same regimen as, 12 other patients who were melting down and getting PEG tubes. This guy was just breezing through treatment. So we started to get very suspicious. We're like, are we turning the machine on? So by week 4, he still had nothing, which was totally unheard of. So we said to the guy, what are you using in your mouth? Like, this is really a miracle. And he said, oh, my daughter's a dentist, and she has this, magic red light, and she's been shining it on my mouth. And we were like, really? So we called the daughter, and we talked to her, and we said, what are you doing? And she, she said she had this laser, and at the time we had no idea what she was talking about. She was powering it down, and she was treating his whole mouth. He made it all the way through treatment with no oral mucositis. So, of course, we started looking into everything. And that's where it all began. And it's been incredibly, incredibly amazing. Incredibly amazing. So we started doing a lot of literature review, and to date there's more than several. There's a lot of studies out there. As James will tell you, though, there's a lot of not good studies out there, too. So you sort of have to sift through all the crap to get to the good stuff. Despite the different protocols used, these studies have shown that low-level laser therapy can produce some benefit to reduce the severity of oral mucositis and pain. And it was supported by the Cochrane review, which is huge. We found that it was on the MASS guidelines, which is our supportive care and cancer guidelines, and it was also on the Oncology Nursing Society guidelines. So 3 of our biggest guidelines recommended low-level laser therapy, but as I started calling institutions and started calling other radiation therapy centers, no one had ever heard of low-level laser therapy. No one. And so we said, well, we're going to be the first. And so this is just the Cochrane review literature, which shows that PMB may prevent severe OM. It's a review of 11 randomized controlled trials in head and neck cancer patients. They concluded that there was consistent evidence that photobiomodulation applied with a dose of 1 to 6 joules per point reduced OM prevalence, severity, duration, and its associated pain. And then another meta-analysis included randomized controlled trials in various cancer treatment settings, showed that PMB reduced OM risks, decreased its severity and duration, and the efficacy appeared to be similar for red and near-infrared light, although optimal doses may vary between these wavelengths. And when you look at some of the studies, there was just a study that came out that was positive, but they only treated for 20 seconds per lesion. We do a minute, and I will go over all of that. And then another randomized controlled trial, 18 reported the prophylactic use reduced the severity of OM and its pain in patients treated for head and neck cancer or undergoing stem cell transplant. So like I said, it's on all the practice guidelines. Multinational Association of Supportive Care, MASC, they recommend it. Oncology Nursing Society recommends it. So it's recommended for the use of oral mucositis to prevent oral mucositis in head and neck cancer patients and in your stem cell transplant population. So we said, okay, we have this problem. Nearly all of our patients with head and neck cancer treated with chemo experience some degree of oral mucositis. 20% of the oncological treatment interruptions are due to mucositis. We know that patients that miss 5 days or less of radiation have a better survival outcome than patients that miss 5 days or more. So one of our biggest things when we started this was, okay, let's see if we could just prevent treatment interruptions, because that in itself would be incredible. If we could get patients through treatment without any interruptions, that would be absolutely incredible. So the consequences of mucositis have been estimated to add $20,000 per patient. Especially in my stem cell transplant, that is a lot higher. They get put on patient-controlled analgesia. They're in the hospital about 7 more days. It probably adds up to a lot higher than that. So we wanted to dramatically decrease the treatment breaks secondary to OM, decrease feeding tube placements, decrease opioid analgesia use, and increase patient satisfaction. And so we put together a study, and that's what we wanted to look at. So our physicians at UPMC Shadyside, we participate in a head and neck multidisciplinary clinic, which is fantastic. And for those of you that have universities that are close by or work together with the hospital, being part of a multidisciplinary head and neck cancer clinic is fantastic. We need dentists there. You are such a vital part of our head and neck cancer patients' outcome and survival. And I know you don't think that, but you ultimately affect their survival as well. Patients are discussed from not only a disease management standpoint, including potential enrollment in clinical protocols, but in terms of individual patient feasibility in completing therapy based upon the disease state and social circumstances. So a necessary component of the clinic and the management team is the prolongation of treatment, whether it's from pain control, weight loss, or other factors that lead to inferior outcomes. And remind me to talk to all of you about something that doesn't do with the laser, but I want to pick your brains. As a result, low-level laser was a welcomed addition in the tiresome management of oral mucositis resulting from chemo radiation. So we looked at patients receiving definitive treatment for malignant neoplasms in the oral cavity and oropharynx with a technique known as intensity modulated radiation therapy, or IMRT, which is a pinpoint type of radiation to the facial fields equal or higher than 70 gray. Before commencing on treatments, patients underwent an oral care protocol, including oral examination, preventative dental treatments, instructions for oral care during radiation, and mouth washes, and obviously their fluoride trays that you guys provide. At the commencement of radiation, patients are treated with either the Thor laser system, the LX2 control unit, which is 1390 milliwatts, 69 diode LED cluster probe, is used to treat patients based on the following protocol. So what we do in our patient population is that patients do receive the treatment immediately following their radiation therapy. So as soon as they get off the table, they come right to me. And we treat their mucomucosa, 1, 2, 3, 4. We treat their tongue, and then we treat their soft palate. We don't do the 4 spots on the tongue. We do the tongue, it's a time issue. It has nothing to do with, what we thought was better, but it's just, a time. They stick out their tongue. We have the larger LED clusters, so we can cover their whole tongue with that. Then we use the intraoral probe, and we cover their soft palate on the 2 spots on their soft palate. So they get this every Monday, Wednesday, and Friday while they're on radiation therapy treatment, and it's immediately following their radiation. And there is some controversy, should you do it right before, should you do it right after? We chose right after because I have 3 nurses in my department and I have 17 therapists, and we treat about 150 patients a day. And if I hold up a patient because I'm not available to laser them before they get on the table, everybody gets really cranky and it's not worth it. So we get them right after they get off the table. So what happened was we had treated probably about 25 patients, and word got to the medical oncologist, and they were like, we want this. Like, why aren't you doing this for our patients? And so we started added to the study, and we started including the stem cell transplant population. So we used the prevention of oral mucositis with low-level laser in the stem cell population. There are some good studies out there. We started doing literature in the stem cell population, and there were very favorable studies in that arena. So we said, okay, we can start adding the stem cell patients to the protocol. So this is just one study that was published in the low-level laser group. 57.1% of patients had an OM grade 0, 9.61, 33 grade 2, whereas the control group, only 4.8 of patients were free of OM, which is huge. So we added the stem cell transplant patients to our protocol, and we do the same thing. So these patients start on the initiation of chemotherapy. I will tell you, in the chemotherapy population, it's incredible for prevention, incredible. And we have to start them the day they start chemotherapy. If you wait till after they're done with chemo, even if they have no ulcers, they do have sort of a poorer outcome than patients that we start on the initiation of chemotherapy. And it's the same thing. We do them every Monday, Wednesday, and Friday until their absolute neutrophil count or their ANC is greater than 1,000. So it's sometimes about 18 to 20 days that we treat these patients. So in radiation therapy, 0 out of 35 patients experience a treatment break, and we've now treated over 200 patients now. But 0 out of 35 patients had a treatment break. We saw absolutely no treatment breaks when we introduced photobiomodulation or low-level laser into our head and neck population. That in itself was tremendous, so my docs were completely sold. 3 out of 35 patients had PEG tube placement due to esophagitis and loss of taste. So what's incredibly interesting to us now is it's all relative, right? So what we decided to do is we were doing quality of life studies on these patients in the study, and the quality of life wasn't getting any better. And we're like, okay, they're not getting oral mucositis, their pain scores are lower, but their quality of life scores were still crap because it's all relative. So now they want to eat, but they can't eat because nothing tastes right. So we stopped hearing things like, I can't eat because it's so painful and these mouth sores are awful, and we now hear from our patients, I can't eat because nothing tastes right. Nothing has the taste it should have. So the tides have completely turned to patients wanting to eat, but now they're not able to eat just because they have no taste. So now if we could figure out a way to work on that, we would be golden. So we still have patients that have significant weight loss and need PEG tube placement for that reason. And in stem cell transplant, only two patients out of the 23 that we saw that we anticipated would have incredibly high risk for oral mucositis, 2 of them developed a grade 3 oral mucositis, and that was it. So I now get stat consults for me to come laser patients on the floor, and it's hilarious. I'll get calls on the weekend. I have a patient that needs low-level laser. Can you come in? So these are just some of my patients in radiation. So this is a gentleman that he was about, and these aren't patients that we treated prophylactically. These are patients that actually were rectal cancer patients that got chemotherapy that can also cause mouth ulcers. These were not head and neck cancer patients, but this was interesting. This guy developed ulcers probably about his 2nd week of treatment, and they were incredibly painful, and he couldn't eat. So I lasered him on a Wednesday. He came back on Friday, and this is what they looked like. It was 2 days. And so he felt better. He said the next morning he felt much better. So it did really resolve his ulcers rather quickly. This is one of my favorite stories. So I got a call from the medical oncologist, and this is from a targeted therapy. And this picture does not do this justice. This guy's, honestly, his whole buccal mucosa had a huge aphthous ulcer. So they had started this, and this guy was 35 years old. He had a renal cell carcinoma. They started him on a targeted therapy. And from the targeted therapy, he developed these huge, I mean, they were enormous aphthous ulcers in his mouth. And he said, is there anything you can do for him? And I said, yeah, I mean, we could try to laser them. And the guy was so upset. He's 35 years old. And he said, I am absolutely stopping this therapy. He said, I don't care if I die. There is no way I am undergoing this pain again from these ulcers. So I lasered him. And this was sort of the course of his laser treatment. Now, this was over a course of a week. He had a total of 5 treatments with me total. And we got him down to this by the end of it was sort of by the end of the 2nd week. So this is a guy who was 35 years old that absolutely refused to get his 2nd cycle, or his 2nd targeted therapy, because of the pain from his mouth ulcers. At 35, he wanted to stop all treatment. And so then when he got the 2nd course of targeted therapy, we treated him prophylactically, and he had absolutely no aphthous ulcers at all. So one thing I would love, if you ever invite me back to talk, I would love to bring a patient with me, because I don't do it justice. And this is where I get emotional. See, I cry all the time. It's amazing what it has done for the oncology population. It's amazing. And so, like, he touched my heart so much, because I always say, you're going to be my poster child. Because he was really one at a young age that could not take the pain of oral mucositis and just wanted to give up, and we got him through. So I would love to have him up here next to me, because he's the real hero, not me. And so finally, my last slide is, you know, we always felt like we were swimming and flailing, and we had nowhere to go with mucositis. And it was very frustrating as a nurse, an advanced practice nurse, that I couldn't get it through the heads of my oncologists that we need to do something about this. And in my 25 years of practice, I have seen all the mucosal agents come and go. I've been through literally 15 of them. And they always come to me, can you try this new agent? Can you try this new one? Can you try this new one? And nothing has been successful except the laser. And I'm not going to stand up here and say, oh, okay, it's like, you know, it's all great fairy dust. I mean, I would love for it to be a home run. I can't say that it's a home run. I have a patient now, I've been lasering him, and unfortunately he broke out in oral mucositis the other day. There are the patients that still do develop some oral mucositis. But our head and neck cancer patients that get chemo radiation with cisplatin, we have seen no oral mucositis, where these patients used to get PEG tubes and be on treatment breaks. We have a lot of trouble with the targeted therapies, and you know, someday I'll sit down and pick, you know, James's brain, but you know, they are very different agents. So those patients still struggle through some oral mucositis with some of the targeted therapies. You know, those are the patients that get the bad rashes, the Erbitux patients. But now I feel like with the laser, we just have this huge tank now that we can just attack oral mucositis and make it much better. So thank you so much. I have to pick your brain on one thing though. So we were finding in our patients that those that we weren't treating prophylactically, when they have metal fillings, we have a lot of radiation scatter off the fillings, and that's where we were seeing the mucositis. So we've tried everything. We used cotton rolls in there to sort of separate the buccal mucosa from the fillings. We've used wax, but I just read an article about dentists making rubber silicone, or like silicone trays for patients who have dental fillings. Do any of you do that? You do? Really? I know, our dentists don't. And so patients wear them to prevent the radiation scatter from the, okay, I just read an article about that.
Thank you, Annette. Actually, she said she wants a patient. I'm going to tell you a story.
Oh.
I lost my wife 2 months ago. She had cancer that came back. When it came back so aggressive, we went in for a consult. Everybody knows how much, like, I am the guy, ultimate guy doing low-level lasers. So I was going to treat her. But what happened, hers came back so aggressive, we thought we were going for a consult. They said, you were in total liver failure, going into kidney failure. You were starting 4 hours of chemo now. You have 1 hour for lunch. We're starting, and we're going to put you on a huge, inject steroids, and huge dose of steroids. The next day she had mucositis. On the steroids, we couldn't stop it. And I lived 2 months of mucositis. And honestly, that was probably, of all the things that happened, that was worse than the last week, even when she was in the hospital dying. I mean, it is such a horrible disease. Till you've lived it, you can't appreciate it. And I've lived it. And it is there. And one thing I urge every one of you, one thing I found, there's a huge resistance amongst oncologists. They're scared to death of low-level lasers. They don't understand it. They're afraid it's going to affect their therapy. It's going to prevent the free radicals. And what I urge you to buy a copy of today's program. And if you work with the hospital or work with oncologists, please give them a copy of this program. I'd love to get it out there. We need to get this done. I urge every one of you to try to be ambassadors to get this done, because having lived it, I know how important it is. So that's what I wanted to end here. So I thank you. We're going to have some questions now. Is there microphones? Somebody got the microphones? Okay. If we have,
I can hear.
yeah, no, we just need, because we're recording it.
Oh.
We'd like to have them do it, so then when the people are asking questions, they actually come up on the recording.
Just repeat the question after that.
No, it's got a microphone now. Okay, Mel?
Hi, Annette. And
Hi.
first off, I was looking forward to this. I was the director for last year's program, and I wanted to get you then when I heard about you. And thank you for doing it. I have a question and comments.
Okay.
First off, you definitely should pre and post load. Next off, I didn't notice you doing anything to activate the lymph glands, and you should definitely do that, because that's going to help you reduce the inflammation. That's one of the great parts of low-level laser. Not to add to your workload, but low-level laser, I've also treated patients for esophagitis. It works. Are you getting secondary myeloplastic anemia patients?
No.
You're lucky, because it works on those too. And are you seeing any that are developing pemphigoids from this?
No.
Okay, because it works in that also.
So the biggest thing with not treating the lymph nodes, especially in our head and neck cancer patients, is exactly what you said. They're just worried about, a lot of these patients had disease in their lymph nodes, and they're worried about tumor progression, or that's the biggest thing.
Are you doing any acupuncture points?
No, but we could, yeah. I know it's a time thing, right? They throw everything at me now. I am doing a Dupuytren's right now. I do a lot of GVHD. Oh, you don't know, everything. They just toss everything at me. Yes?
Okay, another question? Somebody's got a microphone. Okay, Scott?
And can you just explain to them some of the initial resistance you had from
Oh,
oncologists?
absolutely. So one of the big things is, it's a big joke, right? So when I said we want to do this, and I'll tell you another great story. When I said I wanted to do this, they were like, that's quackery. Are you kidding me? And I was like, and so I started pulling up the peer-reviewed literature, and so what happened was I applied on my own for a grant. I did not get any help from administration whatsoever. I applied for a grant. I got the machine. Well, then what happened was it was starting to work. So I was doing all the radiation patients. I was doing the stem cell transplant patients. I was working till 9, 10 o'clock at night. And my administration actually got called into a meeting, and they're like, oh, how are you getting paid for this? And I was like, I'm doing it out of the goodness of my heart. Oh, no, we need to get money for this. And so then I had to go through, oh my gosh, months and months of meetings about how can we get money for this? And I'm sitting up there going, are you kidding me? These are stem cell transplant patients in the hospital for 90 days, probably, $30 billion worth of, and you want to charge them for the low-level laser? So it got insane over that. It just, how do we get money? And then what happened is that I had a patient, she was head of our quality and safety at the hospital, and I always say things happen for a reason, right? So she developed really bad oral mucositis, and they called me to help her because she was the head of quality and safety for the hospital, and we didn't want anything bad to happen to her. So I lasered her, and she had such bad mucositis she couldn't eat. In 3 days, I was bringing her in, because she actually lived about 7 blocks from me, and we started talking about her favorite pizza place. So I actually she's like, I feel so much better. So I surprised her and brought her in pizza from her favorite pizza place 3 days later. The second time she came in, now in that cycle, she lost 45 pounds. She was on a patient-controlled analgesia. She was in the hospital 10 more days than she should have been. Second cycle, exact chemotherapy, nothing changed. I prophylactically treated her. She made it all the way through with no oral mucositis. She, on her own, wrote another grant, and we now got 2 more units for our hospital, which we are doing training Monday. So now we have 2 more units. So we now have 3 at the University of Pittsburgh. But it's really been the patients who, when the docs come in, they say, you know, I'm like the queen. I walk up there and they're like, oh, the laser girl's here. You know, it's amazing.